Welcome, everyone. I'm Dr. Tara Kiran. I'm the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto, and also a family physician at St. Michael's Hospital. And I'm really delighted to welcome you to our session on our COVID community of practice on vaccines. We're delighted to co-host with Ontario College of Family Physicians. And to that end, I'm going to turn it over to Dr. Liz Magat to give us a bit of an introduction.
So good morning, everyone. We're really delighted that you're coming to join us. This is our third week in a row offering this, although it's been many months. We've been providing or hosting the community of practice along with the University of Toronto Department of Family and Community Medicine. We have three terrific panelists with us today. They will introduce themselves in a moment, so I won't do that now. Just to note, this is Maine Pro certified, and you will receive an email with that information after the webinar. I'm going to start with the land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am calling in from Ottawa, which is unceded Algonquin and Anishinaabe territory. I'll hand back to you, Tara.
Yeah, so I mean, I think always a great time to reflect when we do the land acknowledgement. And today I just wanted to shout out to my colleagues, Drs. Janet Smiley and Suzanne Schuch, both of whom are Indigenous family physicians. And together with their colleagues, they founded a community-based Indigenous-led COVID assessment center in downtown Toronto, where there's Indigenous staff serving Indigenous people. And we know, the path towards reconciliation does mean many more Indigenous providers caring for Indigenous people in ways that are respecting cultural traditions. So it was really wonderful to see this. Next slide. A reminder that, we've had many past sessions and these are all available on our website. So please check them out. I already saw one question about a PowerPoint deck that we said that we would share, and that PowerPoint deck is actually available on our website. Next slide. We have a great committee that plans this, but we always welcome your input, and so we'll be asking that with an evaluation at the end. Next slide. Today, we are delighted to have a diverse group of panelists who are going to be talking about everything from vaccines in Indigenous populations up north to the long-term care delivery to some of the rollout logistics. Next slide. And of course, we also have our co-hosts, Liz Magat and David Kaplan. Next slide. So I'm going to turn it over to our panelists one by one to just introduce themselves and speak to their conflicts. Maykat?
Good morning, everyone. Thank you for that land acknowledgement. That was very nice to see. So my name is Maykat. I'm a primary healthcare nurse practitioner. I'm located in Thunder Bay, which is the traditional lands of the Fort William First Nation. So as the chair of the Anishinaabe Nation, I'm not doing the presentation now. I'm just
no, just you can introduce yourself. Yes, that's
okay. So I'm the chair of the Anishinaabe Nation COVID-19 task team.
Wonderful. TFM?
Hi, everyone. Thanks so much for having me here today. I'm a family physician in Toronto, in East Toronto to be specific, of which I'm also the physician lead. So I have honoraria from my family health team as the lead physician, and I've also been a founding director of the East Toronto Family Practice Network, over 200 family physicians in East Toronto, and receive a small stipend from there. And I have a small medical education grant from my hospital, the Michael Garron Hospital.
Thank you. Daniel Warshawski.
Hi, good morning, everybody. I'm Daniel Warshawski. I'm a public health physician in the Office of the Chief Medical Officer of Health for the Ministry in Ontario. and I don't have any conflicts of interest that I know of, and maybe one day hope to have when this pandemic is over.
Next slide. Liz?
Hi, everyone. As I said, I'm Liz Mugga, family doctor in Ottawa, and I'm the president of the Ontario College of Family Physicians, and I do receive a stipend from them for this work.
David?
Thanks. I'm David Kaplan. I'm a family doctor in North York and the chief of clinical quality at Ontario Health, where I receive employment income, and I receive an honoraria from the OCFP for this work. And I feel like, I don't know what number this is, Tara, but I feel like if it goes on much longer, I'm just going to replace me with like that picture of Bernie Sanders that's making the rounds of him sitting at the inauguration, because either that or I feel like it's like he looks like an older obstetrician waiting for a delivery. He's been called too early, but I sort of feel that way. It's been like number 14, I think, right?
Yeah, or more. I think maybe 15 or 16.
Waiting for the pandemic.
So I'm Tara Kieran. I'm a family doctor at St. Michael's Hospital, in the Vice Chair Quality Innovation at University of Toronto, and I do have some declarations there based on grants that I've received and salary support, but the only one with a commercial company is Gilead Science Incorporated for a grant for Hep C. Next slide. So we're delighted to welcome all of you. So many of you are from the GTA, but we're delighted that so many of you are from outside the GTA as well. I think we had up to more than 800 registrants for today's session. And we already have about 550 with us, which is amazing to see. Next slide. As our numbers have grown in the community of practice, it becomes a little bit more challenging to answer all of your questions live. We have asked you when you registered what questions you have for us today that you wanted to have answered. And I'm listing here kind of the top 5 questions that came out of those responses from you. And these are the questions that we're going to really focus on making sure we answer today. So you'll leave here today with these answers. So that includes things about the current vaccine rollout plan in Ontario, in not just urban areas, but remote and rural communities and for different populations. It includes what is the role for family doctors in the rollout and how can we prepare our practices and support our patients? When will community family doctors get the vaccine? What are the implications given the change in Pfizer's vaccine availability? And will the second dose be delayed for those who received a vaccine? And if so, how long and what are those implications? So those are the 5 questions that we're going to really focus on and make sure we answer. And of course, we'll also try and get to other questions today, but of course, it depends on the time as well. Next slide. There'll be less focus on actual questions about the vaccines themselves. And so I'm going to direct you to these great resources, including our community of practice sessions, where we have the recordings from past sessions, as well as a resource list that might be very helpful to you. If you missed Liz Mugga's great newsletter that summarized a ton of resources, you can get that on the Ontario Family Physicians website. And of course, there's a Center for Effective Practice. And some of you may not have seen the New England Journal of Medicine FAQ, which I think is amazing. It's really has a lot of the top questions that we're seeing here being answered by experts. Next slide. So of course, many of you have already started to ask questions today, which is wonderful. And we ask you to put those questions in the Q&A box. It's just a lot easier for us to keep track of. You can use the chat though to share comments or share resources with others and connect with others. So one thing that's important is because we have so many participants, if you can vote when you see a question that you like, instead of retyping it, if you put up a thumbs up, that helps us to prioritize that question. So we'll be prioritizing questions that we see many people have on the call and that rise to the top because of that thumbs up. So please do use that and take a look at some of the questions asked, and also look at the answered column because some of them may already have been answered. Next slide. So without further ado, I'm so delighted to turn it over to our first guest panelist, May Cat. May, we know that Indigenous populations are one of the priority groups for vaccination for COVID-19. and for good reasons. And we actually on this community of practice haven't spoken very much about what that strategy looks like. And we know there's some real challenges, especially when we're talking about delivering vaccines to communities in the remote north. So we're looking forward to hearing more from you about what vaccination looks like for Indigenous populations in the north. Next slide.
Good morning. Thank you, Tara. So this is the geography of the remote First Nations in an area called Anishinaabe Nation. That's what the acronym NAN means. So NAN is really 49 First Nations in north, 2/3 of the province in landmass. We go from the Quebec to the Manitoba border and anything above the railroad line. So in that area, there are 50,000 Ojibwe Cree and Oji Cree. That's the dialects that we have. So there is a lead for the distribution for the northern remote communities. That's being led by Dr. Homer Tien from Orange, and his team are doing all the logistics. So in that geography, we have the 31 First Nations, and they border the James Bay coast, and again, they're all fly-in communities. So Orange again has a fleet of airlines, and they're also using some of the native airlines in those areas. The geography shows that there's 3 hubs, urban hubs, where vaccinators will return to every day, and then deploy the vaccine out every day from Sioux Lookout, Thunder Bay, Timmins, and there's also a hub in Moosonee. So we are rolling out the Moderna vaccine just because it's one of the ones that can be transported. So the rollout has actually happened last week with a number of the long-term care centers on the James Bay coast and some of the congregated living areas. We have a hospital in Moose Factory run by the Winnebago Health Authority. So they've been taking the lead on doing the James Bay coast, which are predominantly Cree communities. Next week on Tuesday, on January the 26th, there's a northern dot. The most northern dot there is the green one, is a community called Peawanik. In English, I guess it's known as Winnisk. So from that, that's going to be the first community that's going to receive a team from Orange. So what Orange has done, taking the lead, is NAN's been involved in the planning for this, as well as the federal government. Again, there's some jurisdiction overlap here, but the main goal is to ensure that those who want the vaccine receive the vaccine and are certainly made aware of what it is. And informed consent is something that we're really striving for those community members, and to do that with a linguistic, diverse language. We have been doing lots of translation. I don't know if anybody follows Homer on Twitter, but he actually posted a consent form in Ojibwe last night. So those are necessary elements for communication to our community. And we all have legal responsibilities to ensure that our patients are informed and they understand exactly what they're receiving through this vaccine. So the preparation that Anishinaabe Nation and the COVID-19 task team, and we're a group of experts in health and emergency management, and we've been together since the beginning of the pandemic. So our jobs are really to ensure that communication has been rolling out to our communities. We do that through our health authorities. We have about 4 different health authorities across that geography. Our biggest one is in Sioux Lookout with 33 First Nations. We have one in Thunder Bay that covers about 9 First Nations, and then over in the James Bay coast, they cover a number of First Nations in that area. It's a great way to provide services, but it's also a great way to use your network. One of the things about vaccine hesitancy is, people have to trust you. People have to know who you are and believe what you say. So I think we've recognized those principles when we're doing our communications and education and awareness. we've had some leadership forums, and of course, everybody knows Dr. Isaac Bogosh, and he's so popular with our young people, which is great, because I think we're trying to hit the 18 to 29-year-old population to ensure that they're getting out for the vaccine as well. So he comes on to our leadership forums every week and does a Q&A. Dr. Homer Tien is there as well. And so we're reaching out to everybody. Yesterday we spoke to our NAN Youth Council, and again, they have a leadership role in education. So if you have any questions, certainly our medical expert is Dr. Claudette Chase. Some of you may know Claudette. She's our medical expert on the vaccines, and she's available to the people to mostly on radio shows. So thank you.
Thank you, May. Wow, it's like incredible to hear the efforts that have gone in to vaccinate in such a diverse geography spread out over Northern Ontario. I was myself in Peawanuck, I think 15 years ago, so incredible to kind of see that that community is going to be receiving the vaccine along with so many others. I see so many comments in the chat of other people just being really blown away by the work done. And what I really loved is your reflection on the community engagement. You know, you're out there on radio shows, educating, answering questions. I wonder, May, if you would be able to speak a little bit to whether there have been some questions that rise to the top or some concerns among the Indigenous population that you've been serving around the vaccine that you've heard, and how you've been starting to counter that.
So I, you know, media comes into our households as well in the North, and you know, the typical myths about the vaccine, and you know, some of the conspiracy theories. So yes, we're challenging those with information based on science and experience with the vaccines. And we're finding that, you know, again, informed consent, education awareness is so key. We do that through, we have an elders focus group that have communicated some of the messages for the elders. Again, they're the vulnerable people. So very common, what is this? What's it gonna do for me? I got sick on the flu shot. This is gonna give me COVID. So those seems to be the range of myths that are there that we're dispelling.
Thanks, May. I think there's some requests for some of the translated material or handouts that you have. And so if you have that link, maybe you can share it with us and we can put it into the chat or send it out to panelists later.
I could do that. We have websites on the NAN website, and everything's translated on there. So that's the easiest one to go to. It's, I don't even know what it is actually. But Anishinaabe Aski Nation website, you can find all our materials. Thank you.
Thank you. So we've got a lot of other questions from our audience as well. And so maybe we'll just take a couple before we go to our next panelist. So, you know, one that, you know, people are wondering about is we've got 2 vaccines approved in Canada, but what's the current timeline for the AstraZeneca vaccine approved by Health Canada? And I don't know, Daniel, if you had any thoughts about that or the other vaccines that are going to be coming?
Sure. Yeah, I can speak to the AstraZeneca one first. So that one has been submitted for approval to Health Canada, as we know. We're not expecting to see approval, probably another 3 to 4 weeks at least, sometime in mid-February. So as we're all probably aware just from the press releases, there were some interesting results in their analysis. There's no reason we should expect a half dose and a full dose to be better than 2 full doses. And so because of some of those other strange statistical anomalies, Health Canada has asked for additional information from AstraZeneca before finally approving. But we're all very hopeful it'll be sometime mid-February.
Thanks, Daniel. I think then there's also questions, you know, about the vaccine being approved, Pfizer in particular, for the 21-day interval. And we had that question a lot also before the panel that people submitted. So we know though that now with the Pfizer vaccine shortage, that may have to be lengthened. And in fact, NACI has said 42 days is okay. So can you maybe comment on on, that change in policy? What does it mean? Is that something that we need to worry about?
Absolutely. So the technical product monograph for Pfizer suggests that the second dose should be within 21 days. But in the actual trials, their range for the second dose was anywhere from 21 to 27 days. So we do have more data than just the 21 days in particular. They didn't go out to 42 days specifically in the trials, but NACI, based on consultation with a huge variety of experts and reviewing the data and knowing what we already know about the immune response for other vaccines, has deemed it safe to get the second dose up to 42 days afterwards, and that we would expect to still have a similar immune response with that. I'll say that for Ontario at this point, we are still recommending, especially for high-risk individuals, residents living in long-term care homes or retirement homes, they should be getting the dose at 21 days to 27 days afterwards at most. It's more for the people who are lower risk, so healthy, younger healthcare workers, that would be extending up to 42 days. But we're, in Ontario, it's very clear we're not extending past that 42 days that NACI has recommended, even though we have heard that in other provinces.
Thank you, Danielle. So, I think that's a good segue to our next panelist, Dr. TFM. We know that long-term care really is where the majority of deaths have occurred for COVID-19. And in wave one, I think it was 80% of deaths were in long-term care. And unfortunately, there's still a large percentage in Ontario in outbreak situations, and many deaths continue per day. And so that's why there's been this urgency to need to vaccinate our residents and staff in long-term care. I think there was a report released just yesterday or the day before that talked about how just even a 15-day earlier deadline in vaccination would, so from instead of February 15th having everyone vaccinated January 31st would save something like 580 lives. So just incredible how important it is, speed for this. And so Tia, you've been on the front lines doing that vaccination in long-term care and retirement homes. And I think a few of us have seen your photos on Twitter, you and your team with Team Vaccine, and we've displayed some of them here for others to see. We've just been inspired by some of the stories. I've been inspired by some of the stories you've told, and I wonder if you could share with the audience sort of the journey of how, what's it been like vaccinating long-term care? What are some of the logistics that you've encountered, and what are some of the lessons, and how have you made it happen?
Yes, thanks so much. And I think this story contains a whole bunch of answers to maybe the questions you also have submitted ahead of time. I wanted to just leave it at this picture because it'll be kind of a translation into the very practical aspects in what happened here January the 6th, when in my community in East Toronto, over 4 days, 6 teams out every day, 8 to 9 to 10 hours, completed vaccinating over 22 long-term care and retirement homes. And we completed our task essentially while at the same time I heard the news while we were carting from senior to senior that Doug Ford announced that we should be completing that task by January the 21st. So that's why arms up and hurrah at that moment when we finished that day. But as you can see, it's usually a team of between, 4 to 5. Now we've headed down to 4 staff, doctors, nurses, family docs, emerge docs, and nurses from our hospital, but also our various primary care teams. And we have the cart, and this day we pushed it across 7 floors. My feet were hurting. We have on it the pre-drawn vaccines that took us about an hour to draw up 200 syringes, cover them from UV light. And that we used Moderna in East Toronto. And so we essentially carted it. Now on the second round in smaller homes, we have 2 docs or nurses stay downstairs to vaccinate the staff, while the other 2 go from floor to floor. So I think that'll be our strategy when we go back for the boosters starting end of next week. So that's essentially the practical parts. But let's go one step back and look at the higher level picture. Next slide, please, Brian. So to step back, for those of you, just if nothing sticks, I would like to just leave you with 2 of the kind of messages and slogans that I put out there. The first one really is can we come together because we care about the same things? And I think that that holds true for everything that we've been doing throughout the COVID, the pandemic. But the first one was really pre-pandemic. My East Toronto area, just like me, I have a picture of the geography out here. So this is Toronto, and then zoomed in specifically East Toronto. And as you can see here, Toronto has been hit very hard, and specifically the east and the west of Toronto, where most of our lesser advantaged communities reside. And so I practice in the east of Toronto, and we were very aware that we had to do different strategies in order to keep our communities safe. And so I think the power of coming together really lies in that with our first wave OHT, we rallied and got all of the 260 family docs that we knew were in East Toronto. We got 200 to sign on to say we want to be the primary care partner in our Ontario Health team. And we actually incorporated as a not-for-profit primary care corporation, family docs, solo, group, capitation-based, all of that. And so when the pandemic hit, we were ready to go and say to our hospital, here we are. And actually, some of our family doctors serve in long-term care homes and retirement homes. What do we do now? And so already back in March, we rallied, got all the names of the physicians serving these homes together. Since March, we've had weekly IPAC rounds on Zoom with our IPAC team from the hospital and our retirement home and long-term care medical directors, family doctors, just like you and I. And we mapped it out, as you see here, against 4 hubs, that's what we call them, so that we essentially can map all congregate housing, actually even the shelters we've mapped out against these 4 geographies. And I think that will serve us well when we go out to the next wave of vaccination, which will be mobile units. But we essentially were ready to go back in March, April, May already. And so next slide, Brian. When December 26th, the call came, all right, hospitals will be tasked to roll out the very first vaccination drives, and Moderna was given to UHN to distribute to the hospitals. We essentially said, hey, we're right here. We're 200 family docs. We're all willing to put needles into arms. How can we get involved? We were also the ones actually staffing all the assessment centers and creating that. And so we have a fancy, not so fancy online scheduler system that fills within literally 3 minutes of doing the call out to all of our family docs. And so our hospital said, all righty. And so here the slogan really is, if you want to go fast, go alone. But if you want to go far, go together. And I think that that holds true for all of us. I saw all of your pleas. Hey, how are we involved as family docs? Will we get involved? How can we get involved? And so it did take a little bit of reminding, hi, we're still here. We're all here. We're part of this. But our hospital right away said, sure, let's distribute the shifts out to everyone to participate. And so we also, and that's another thing of coming together, under Camille Mieux from UHN, the chief of family medicine there, she did another call out to all of us family docs, and David is part of that. So we came together representing the different regions to really form Team Vaccine, because look at the logistics. 166 long-term care homes and retirement homes just in Toronto alone, close to 50,000 residents and staff. That Excel file that we saw was tremendous. In order to achieve that, we really need to go together and not alone. And it's not just hospitals that can do that to achieve it as fast as possible. And so essentially all of us came together. And so David Kaplan, Rebecca Stroller really covered North York. Alan Grill and his team covered up in Markham. And so it just was a whole wave call out, Camilla Mieux, the whole center of Toronto, to do it together so that we can go fast. And I know that all of you are very eager to go and participate. And so I think really finding out who your public health unit leads are, who your hospital leads are, and really very strongly reminding them that together we can go far and fast, so that we can move on to the next waves. that we're all eager to participate in is important as we prepare for the wider rollouts. I think I'll close here, Hannah.
Thank you, Tia. Incredible work, and just like incredible that your team finished on the day that the mandate came out that we needed to vaccinate long-term care by January 21, and you guys were done. That's pretty incredible, and I think you've been very humble in your own role as a really strong leader in bringing together that community of family doctors to be one and to be unified. A unified partner with the local hospital. So what a wonderful success story that we can hopefully replicate across Ontario. So, I mean, I think there have been some questions, about vaccinating elderly individuals and, whether that poses any risk. And I think, Tia, you wanted to speak to that as well. Maybe I'll turn that question to you.
Yeah, I saw a lot of practical questions from all of you about, how safe is the vaccine in the very frail, and all the practical questions. Well, this patient is on warfarin. Can I give the vaccine? This patient has lupus and is on prednisone. Can I give him the vaccine? So these were all practical questions that came up. And don't forget, we were doing that January, early on. But certainly the Canadian Thrombosis Society said it's fine. Just, put more pressure on when you give the vaccine. And the Rheumatological Society has made clear statements as well. If you're over the age of 70, your risk of acquiring COVID and dying from it is so high, get the vaccine. And the only, MS, lupus, rheumatoid, even if you're on immunomodulators, we don't know exactly if you'll mount the same amount of immunity, but there isn't an allergic reaction to that. I think what I was very impressed with as well is there were a few patients who said to me, but I have a whole bunch of food allergies, and I get hives when I eat strawberries, whatever. So we just watched them more carefully for 30 minutes, and we would have, we'd vaccinate and tell the staff to look out for that one, and then we rounded back before we went to the next floor. Of the vaccines that we've given, and I put the slide out there, of all the Pfizer vaccines and Moderna vaccines we've given in our geography, Moderna 0 reaction, Pfizer 1 reaction, and only in someone who was actually known to be extremely allergic to, I think, 10,000 different things. So I think that really makes me very confident in giving that vaccine and not being super anxious around having to hover over the patient with my EpiPen. But we did go, we had our EpiPen on the cart, ready to go. Nothing happened.
Yeah, and I would say, and first of all, shout out to, you said to Rebecca Stoller and me, it was Rebecca and her team. I just provide the cheerleading support. So credit where credit is due in North York. But same thing, I think they had 1 reaction in over 2,000 doses. So, and seemingly quite, you have to be ready for it, but quite safe.
I think I wanted to speak to one more thing, if I may, because it came up in the questions. And I know that I think Neely is in the audience, who wrote a strong article about Ottawa. But I know many of you have been asking, what about me as the community physician? Where is my place in line? When will I get my vaccine? And those of us involved in doing assessment centers and vaccinations, will I have earlier access to it? That was a big pledge of ours as well, both in Toronto, across all of us doing this work, but obviously for all of us family doctors across Ontario. And so I did bring that up yesterday at the Primary Care Advisory Group as well. And I think there should be a statement coming out. But certainly I think the clarification, I think in another communication, hopefully has come out that those of us involved in all of these work should go ahead in the line to get vaccinated earlier on. So if that's not the case yet, obviously do reach out so that we can keep on lobbying further. But supposedly that was rectified and clarified, that we do go ahead. And because we're a network in East Toronto, again, I can only speak for the power of going together and standing up together. We said we've done all of this amazing work. Those of us who do this work should have access ahead and in the same ranks as everyone else. And we did get all of our family docs, community docs vaccinated.
Daniel, I wonder if you wanted to speak to that question too about community family doctors getting the vaccine.
Sure. So all healthcare workers are part of the phase 1 of our vaccine rollout, which means that we're expecting by end of March to have healthcare workers vaccinated. With the current shortage in the Pfizer vaccine, we might see that that is a little bit delayed. So as we know, Pfizer has been delayed. Initially, we were down to 50% of the expected doses over the next 4 weeks, but that's been cut back even more. So Canada's not receiving any doses in the next shipment of Pfizer. And Pfizer, to put this date, is the main vaccine that we're using in healthcare workers. Community physicians are still part of healthcare workers in phase 1, but in terms of the overall prioritization plan that's been released with the framework of who and what specific risk factors you have, your likelihood of getting COVID, they're slightly lower down than those who are frontline in hospitals or in long-term care centers. So we, again, are expecting all community physicians, the vast majority, to be vaccinated by the end of March. The number one thing will be if we can make up the supply in terms of Pfizer Moderna that we are currently missing.
Thanks, Daniel. So I just want to say, Tweena, there's a ton of comments in the chat just saying how amazing and inspiring your story is. I think Darren Larson says it speaks to the impressive peer leadership and the power of a collective meeting, shared needs, and a sense of community. This can happen in big cities as we see here, because I think often people think, oh, that can only happen in small towns. And then, I think others like Karen Wayman mentioned that, our own teams were inspired by the work that you guys did in the West. Long-term care homes have been supported by St. Joseph's Family Medicine in a similar way. So, I think people are just really blown away by that model and the leadership. And I think, Boyd, that family medicine is out there doing this work. So I think Alan Grill also mentioned that some public health units are offering vaccination to family docs volunteering to vaccinate. So if you're a family doctor in the community looking for a vaccine, that may also be something to think about. And I think Sid Feldman said something about, how he's very proud of the collective work in helping to vaccinate LTC residents. But as an LTC physician and medical director, he'd like to acknowledge the tremendous amount of work by LTC physicians and teams in obtaining consent, prep, and follow-up to get vaccinations done. So definitely a lot of work behind the scenes that makes, when you go in then it makes it efficient to go in and put vaccines in arms. So I'm gonna, so lots of great chatter there, and I'm gonna just turn it over to a question that I think relates to the topic we've been talking about. And this is just, we're focusing on vaccinating people living in long-term care, but Barbara asked, practically how seniors from the community, often sometimes without a family doctor, will access and be in line for the eligible vaccination when their time comes. Who will contact them? So far she sees her patients 80 and 90 waiting patiently at home. I don't know, Daniel or David, whether you guys wanted to take that one.
Sure. Yeah, I'm happy to, and David will probably have some good insights as well from the operational standpoint. But so seniors living in the community are part of the phase 2 of the overall rollout. So we'd expect the vaccination for that group to begin starting in April likely. And we'll probably be seeing age bands in terms of when they become eligible, starting with those over 80 and decreasing in roughly 5-year intervals. In terms of notifying those people, there'll be very, very broad campaign from the government saying this is whose turn it is to go get vaccinated. But at the same time, we'd expect any family physicians to be actively calling up their patients to make sure that they'll be aware. And at the same time, looking at other things that we can do are there mailouts we can be doing that would be helpful. Overall, the vaccine rollout for phase 2 is really being coordinated by local public health. And so local public health will also be reaching out to people, and we'll be seeing exactly, is it going to be done primarily in mass vaccination clinics that are held by local public health? What involvement specifically will primary care have in that part of the rollout? It's probably going to depend locally on some of the considerations of geography and where providers are available, as well as, specifically which patients need to be able to get the vaccine at that point.
Yeah, so I would just add, so, right now that guidance, as Dan was suggesting, is coming out. A number of system partners are working on the right queries so that we all can find our patients in our EMRs and then use whatever method we want to ensure that we reach out to them proactively so they get their vaccine and know where to get it, whether or not it's a mass vaccination clinic or a primary care hub, like Daniel said, depending on the geography, or a mixture of both. There's definitely a group working provincially to work with the public health officers to try to find what is the best interface between primary care and public health. And I would say, since the Christmas holidays, the interaction between our local public health units in general and primary care probably has never been as well integrated as it has been in the last month and a half. So, a very positive, I think, relationship developing between public health units and primary care, and trying to spread that positivity across all 14.5 million citizens. So more to come, but definitely it's being worked on daily.
And maybe I'll just, if I could just jump in on that provincial effort, because, I think the number one issue here is the vaccine supply, obviously, in terms of what we're doing. But just what you're hearing, I think, is that variation across these 34 different public health units is an opportunity and a challenge. I guess the opportunity is you can really do what that particular region needs. The challenge is we really have to make sure that there is a evenness in terms of the principles that are applied across all of those. So that's been a major activity for those of us at an association level. So the OCFP and with the SGFP really pushing for, some of what we're hearing here around similar principles being applied across all 34. But I will be honest and say, this is a really important opportunity for primary care and public health to work together, but some of these relationships are new. And so we are learning as we go. And I think celebrating right across the province's stories like what we heard from Tia is really important. And, what is required of the anchor organization, so to speak, which in that case was Unity Health, what could potentially then be provided by your local hospital, your OHT, a large group of family practices. I think it's going to look differently. So how do we ensure that each of those 34 regions are scaling up what we've already learned is going to be really important. So just to underline that, we know it's frustrating because some of the messaging has been different and communication hasn't been great, but we're on it. I would say as associations, it's a major priority for us at the OCFP.
Yeah, and it's been really nice to see the coordination of primary care associations come together. So the SGFP, the OCFP, AFTO, the Nurse Practitioners Association, and more. And we know that, I think today it was announced that pharmacy technicians are going to be allowed to give the vaccine as well as pharmacists. So there's a large workforce that can be coordinated, and it's going to be great to have everybody, hopefully all hands on deck to be able to do that kind of work. I wanted to actually move it to, before I go to our next question, I just want to acknowledge a couple of other things that are in the chat and relate to the issue of variation. So I think one of the frustrating things is that, so far with the rollout as well, there's been a lot of variation, not necessarily a public health unit, but related to the hospitals and the hospital policies. And so we see some people in the chat saying, they feel very grateful as community family doctors that their local hospital did include them in the vaccination, and others feeling very frustrated that they were left out. And so just acknowledging that difference in the province. But I'm going to change gears for a moment, just because one of our most popular questions is more of a technical question, and I'm going to turn it over to you, Liz, to answer this. So Rhonda Wolanski says, I have a question on the Prolia injection for osteoporosis. It's a monoclonal antibody. Is there any advice in delaying this shot if due and the patient is about to have the COVID-19 vaccine?
So I thought I would take the initial stab at this because we looked at some of these questions with our, when we pulled together that OCFP document that I've referenced a few times to summarize the guidance for special populations. And then maybe Tia can answer what actually happens on the ground. Because I will tell you, we didn't find any specific Canadian recommendations around prolia and osteoporosis. If you look to what the UK and what the US are saying, they're both saying it's safe to take. The UK says you can take them on the same day. You don't need to worry. You take the vaccine and your prolia on the same day, not a problem. The US is saying wait 7 days. So I think my message was there's nothing official yet that I've seen that's Canadian guiding us on that. I don't know on the ground what it actually looked like though. I assume you had some of those patients when you were going through the long-term care. So I don't know if Tia or David can add to that.
Didn't even ask. It's not on the consent form.
Daniel,
there you go.
Yeah, maybe I can add a little bit to that. So as Liz mentioned, the OCFP has summarized the wonderful special populations guidance. So for people who are on monoclonal antibodies, we do recommend that they see their treating provider to talk about whether delaying a dose or timing their vaccine dose and treatment is recommended. So like number one up front is they should receive the vaccine. And if they have to get the same day, that is absolutely fine. The only concern, and it's not even much of a concern, is that you may have potentially a slightly less effective vaccine administration if it's done concurrently. And slightly, I mean, we're talking a couple % in terms of vaccine efficacy likely. So the discussion we recommend people have is number one, so that they're aware that we might have this slight drop in vaccine efficacy. And then if there's the ability to adjust timing of doses, then it's something to consider so that you can maximize the benefit from the vaccine. But if it has to be the exact same time, you go ahead and do it.
Thanks, Daniel. So there's also a question here from Sylvia I'm not sure if I can pronounce her last name right, Murchison. Some healthcare workers have received the second Pfizer dose and have reported significant reactions. One had severe arm pain, rigors, aches, and ongoing brain fog. Is there a concern that the vaccine may cause a long hauler of post-vaccine recipients?
Yeah, I'll start with that one. So that's a really good question. As with other vaccines, we do expect that the second dose is going to have more severe side effects. So to date, most people that we've heard of have minimal to no side effects, frankly, from the first dose. But certainly after the second, people are experiencing higher ones. There isn't any evidence that we have so far or any reason to believe that people getting the Pfizer vaccine or any other vaccine will get the long hauler syndrome from COVID. So, the vaccines are just giving that very, very specific spike protein in terms of what the immune response is acting to, whereas obviously COVID infection, we know has a much larger response to multiple parts of the virus, and we see those vascular considerations added on as well. It's not something we see with the vaccine. So no, we don't expect anybody to have long hauler symptoms from the vaccination.
Thanks, Daniel. So a couple more questions for you. Talitha has asked, I volunteer as camp doctor in the summer at a camp for kids with disabilities. Would campers and staff be considered part of congregate settings so that they could get their vaccines in phase 2?
Yeah, that's a really good question. So at this point, none of the vaccines are approved for use technically in children. So the Pfizer vaccine is approved for ages 16 and over, and the Moderna vaccine for ages 18 and over. The Pfizer vaccine, though, they did study some children aged 12 to 15 in the trials, and NACI in their recommendations has stated that it can be given to children 12 to 15 who are at high risk of exposure and a high risk of negative outcomes. So the group you're talking about, children with disabilities that are at camp, is a group that we would expect to be potentially vaccinated at that part of the distribution, but is going to depend highly on, number one, where we are in the overall vaccine distribution, if there are still higher risk groups. Number two, how many camps are really going to be opening, which is something we're actively discussing right now. They should be open though. And we'll have to see where we are in that point, who's going to be getting vaccinated. But I would hope that those especially high risk groups were able to vaccinate by the summer.
Thanks, Daniel. And so, we all are also hearing a lot about the new variant that's been detected here in Ontario as well now. what do we know about the new COVID variants and in the context of vaccine efficacy? Will the vaccine still be effective against them?
Yeah, so the new variants do have mutations on the spike protein, but none of those mutations are directly on the antibody binding sites that we're concerned about for the vaccine. So at this point, the National Microbiology Labs for Canada have been looking very closely, and they don't see any reason that the current mutations that we have in the multiple variants should decrease vaccine efficacy. Obviously, we know the new variants are easier spreading than the previous variants that we have around. So we do have to really make sure that we're still following all of our public health measures at this time, even for those who are vaccinated. But we expect the vaccine efficacy to be the same.
Thanks, Daniel. So another sort of question about people with immune suppression. So should people with immune suppression hold their immune suppressant medications upon being vaccinated to achieve a better immune response?
Yeah, I think I touched upon this briefly with the monoclonal antibodies, but it's all part of that same group. So the special populations recommendations actually list out the types of therapies where people should be consulting with their provider to determine if they should be delaying doses. Again, the vast majority isn't really that we would delay the dose. It's that you should just be aware it might not be as effective. But for some people, depending on their risk of actually catching COVID, you may consider delaying doses slightly. But again, they can all get them if they have to.
Thanks, Daniel. So I just want to also acknowledge, there's more questions just, about community family doctors feeling really left out of the vaccination. And I think, Chris Sankey is the vice chair of the section of addiction medicine in OMA. And he's raised an important point about the serious inequity in vaccination that's currently happening with physicians and medical staff affiliated with universities or other governmental institutions getting vaccination, while equally or more qualified healthcare providers who work fee-for-service community-based are being given no information and no access to vaccination. This is not consistent with the official triage plan. I wonder if, I know we spoke to this a bit, but I think it's a directed, pointed question.
Yeah, so I mean, I'm happy to take a stab at, I see Liz nodding, but I 100% agree. I'm going to be honest, even within Toronto, my hospital, other hospitals have taken a different approach than, hospitals that are 10 kilometers away. I think that the government and the General's Task Force put out pretty clear guidance on who should have been vaccinated. And for some good reason, there are certain people, when there were extra doses available, obviously we don't want to waste extra doses of the vaccine, but that's a different case than not following the schedule to the fidelity that the government released. And 100% we've been advocating provincially that people should be following the schedule to that fidelity.
Yeah, I would just echo what David said. So I think in our role provincially, absolutely we have talked about that this was egregious. I think all of us as docs would agree that there's a reason to have a proper prioritization of healthcare workers, and we should follow that. And I don't think any of us have problems with that, but that's not what happened. So, I think we've been saying very clearly, look, learn from this. And many of you who I'm sure are on this call, and I know Chris and others have spoken up about this, and that is really, I think all that advocacy is also incredibly important. I think the government heard that, the hospitals heard that, that this is not okay. So, I mean, I think we have to hope that there's sort of a learn, change what we're doing, and let's move on and get this right. But yeah, I mean, it was not okay at all.
Thank you for acknowledging that, David.
Let's hope that that's the only, yeah.
So, I think related to that is, will staff be also our own staff? When will they be able to be vaccinated? Are they in that first phase as well? Or are they in a different phase? I don't know, Daniel, if you're able to answer that.
Yeah, so it will depend a little bit on the nature of the staff and what they're doing. So really it's people who are going to be in direct close contact with potential COVID patients that are the focus for phase one. And so if you're talking about administrative staff that are behind the desk that, are able to wear PPE and don't have prolonged contact with patients, they would really be in phase 2 of the vaccine rollout.
Thanks, Daniel. I also just want to acknowledge there's a comment, I think, about not just, there's inequity within the geographies, but of course also vaccine inequity across geographies, because some communities have just been, not had the vaccine there, and their LTCs, for example, have not been vaccinated. I think there was a question that I had seen, and I'll just put it out there, which was about how to counsel pregnant women, women who are hoping to become pregnant. Should they be getting the vaccine? Is there any concerns related to that? I don't know if, I think it was Tia, you were going to potentially answer that one.
Sorry, Tara, I'm just busy answering all those Q&As here.
You might have answered it already, Tia, but it was about the pregnant women,
Yes.
Women who are trying to become pregnant and trying to conceive. I think you
Yeah.
answered that one probably typing, but I think many people had that question.
Yeah, I think there were actually a whole bunch of them. I think the SOGC very clearly came out when we started our run. Obviously, we didn't have that yet, and lots have asked. And so at that point, it was also an informed consent discussion with the women. But since then, both Unity Health has put a lovely, information sheet together under one of our family physicians in the community. And then the SOGC have put out clear guidelines, and I think they're listed on the OCFP website, both of them, that you can read yourself and then counsel your, women if they're already pregnant or if they're planning on conceiving. But, it's an informed consent discussion, but no evidence that there is any reason not to give the mRNA vaccine to them.
Thank you. So another interesting, question. I have a patient received the first dose of the vaccine on the 6th January. She tested positive for COVID on the 15th, but has no symptoms. When can she get her second dose of the Pfizer vaccine? Daniel?
Yeah, I can take that one. So as long as they are no longer symptomatic for at least 24 hours, they can receive the second dose. So the concerns from NACI about making sure that you aren't symptomatic are really to be able to identify side effects you might be getting from vaccine. And also the IPAC considerations for someone who's actively symptomatic with COVID in terms of getting the vaccine. But we don't have expectation the vaccine works any less well just because someone is now symptom-free but still in their 10 days.
Thanks, Daniel. So Brian, I wonder if you could put up that slide, questions we've received from you. I think we've gone through all of these questions that we committed to answering at the start. I think the one that I think may warrant a little bit just more, if I don't know, from Daniel, David, or Liz, or Tia, or May, what will be the role for family doctors in the rollout? How can we prepare to support our patients? And will we be able to give vaccine in our offices? So I wonder if one of you will be able to answer that question.
So I'm going to start with the here and now. So, and then I'll let Dan and others talk about future. So the here and now, if we look at our phase 1A population, you heard from Tia and others how wonderful we've done in vaccinating people who live in congregate settings like long-term care homes and retirement homes. So in my own hospital's long-term care home, 99% of the residents are vaccinated, but only 38% of their staff or of our staff in that long-term care home have agreed to take the vaccine. So I think in the here and now, we have a huge duty as family doctors, because we are their doctors, to, if we know we have patients who work in long-term care, and you can think about who those people are, to actually proactively reach out to them and say, I'm your family, I'm calling you because I think it's really important that you get the vaccine. Because we know that staff hesitancy is actually probably much higher than hesitancy in the general population. So I think from a here and now, what could we do that would actually make a huge difference to the lives of people in this province is to actually reach out to our patients who are working in long-term care and retirement homes and counsel them to get the vaccine. But that means that you're all here, so you're gaining lots of knowledge about the vaccine, but I think the first thing is to actually become knowledgeable ourselves about the vaccine and about the safety of the vaccine so we can counsel our patients moving forward as well. But with the actual sort of doses and arms, I'll let others speak to that.
Tara,
I know that Yeah, May, I know that you also wanted to mention something, I think about the geographic inequities, perhaps.
Thank you. So there was, I want to just comment on the physicians. So in those northern 31 remote communities, the physicians will be on site in those communities if they can be according to their schedule. They also cover our hospital in Sioux Lookout. Orange has also reached out to the Northern Medical School and Queens Medical School, and they will have residents as well as students and faculty to be part of the vaccine teams that go into our community. But there was a question about non-Indigenous rollout to the north. We haven't been part of that, but it's just Ontario is responsible for the vaccine distribution. So we have 18 non-remote communities as well. Currently on the northern highway corridor, where there's an outbreak happening with the non-Indigenous communities, you know, in Kapuskasing and Long Lac, and there's 4 First Nations there. So I'm not sure how they get prioritized. I think in some ways, you know, we have to also look at non-Indigenous rural priority because again, we don't have a great system of health services. That was just my answer to the question in the box.
Thank you, May. And I'm pleased to share that Dr. Sarah Newberry is going to be joining us at our next community of practice session. And I hope we'll be able to speak a little bit more about Northern non-Indigenous communities as well. Did anybody else wanted to speak about the role of family doctors before we wrap up? David, I think you spoke about the here and now. Do you think that there will be a future where we'll be able to give this vaccine in our offices? I don't know, Daniel or others, if you wanted to comment.
Yeah, and absolutely, we would expect to see that. So as I mentioned, I think in phase 2, we'll, you know, depending on the local geography and the public health units coordination, we may start to see family doctors in offices giving out vaccine or in larger groups. But we do expect that by phase 3 in the summer, when vaccine is more plentiful, and again, this will be somewhat supply dependent, that we'll be doing a broad immunization campaign, the same as we would do for something like flu. So, you know, like I said, supply is the #1 thing that's determining the rollout at this point. So we're going to still have to wait and see where things go with that. But we expect all family doctors to be vaccinating their patients at some point.
Thank you. So we're just going to wrap up in a moment. Brian, can you get to the webinar slide? And Tia, I think you just had another comment. Actually, could you go back a few slides, Brian, to the one that says webinar? Tia?
I just wanted to make sure that we also shared the document. I think that Dan was going to talk to about the different phases and who is prioritized how. I do think it is a very important document that people can then see where the anticipated timelines are for what populations. Not that it's hacked out yet in detail, but just to answer a whole bunch of your questions, who comes when, where, at what timeline. And then remember, everything is frozen for now because we do not have any vaccine.
Brian, can you go back one slide? And if you go backward one slide, this is a document that Tia is referring to, and we did speak to it actually in detail at our last community of practice session. So if you wanted to hear someone speak about it, you can go to that session, but we will include it in our materials as we send out today, so you can take a closer look. Next slide. Did want to draw your attention that there is an upcoming webinar on February 9th to help us to manage anxiety disorders in primary care, which we know is a huge issue during the pandemic. Next slide. Our partners at OCFP, they are, of course, launching Family Medicine Summit, and that's going to be starting on Saturday, January 30th. So just a reminder to register for that. Next slide. We also a reminder of these wonderful vaccine resources that have answers to many of the questions about vaccines, some of which we tried to answer today, but some I know we weren't able to get to. Next slide. And then we do post all of some sessions online, and they are accredited for self-learning. So if a colleague of yours missed it and they wanted to view the session, they would get Main Pro credits for doing so. Next slide. So I wanted to just end by thanking you today for coming to our community of practice session. You will be receiving your Main Pro credits by email in the next 1 to 2 weeks. You will also be receiving later today an evaluation that we appreciate you filling out with suggestions for new panelists and new topics. As well, we have organized our next session for February 5th. And so we hope to see you back again then. So for now, thank you. Thank you for all of the wonderful work that you are doing in this difficult time. And thank you for attending today. And thank you to our panelists for sharing their wisdom with all of us. Take care.